Hello everyone. Good evening. Good morning. Hello everyone. Good morning all. Hello everyone. So welcome to the revision session or the recall session of FMG 2023 Psychiatry. So here we are going to discuss the questions which were came in your recent MCI exam. So let us start. First question. There were 6 questions from psychiatry, and I would say that these questions are pretty simple, easy. 6 questions were there, and these questions were pretty simple. And if you have read psychiatry thoroughly in our classes, you would have marked all the answers correctly. I hope you you all have already marked the questions, the answers correctly. So let us begin. First question. A 25-year-old lady presented to psychiatrist along with her father with complaints that aliens are talking with her and controlling her with some electromagnetic radiations. Aliens asking her to kill all her relatives. Patient doesn't goes to her farm for work and has become asocial. Patient's father told that she has had these symptoms for last 20 years. What will be the diagnosis? So I want to ask you all, what will be the diagnosis? This is a clear cut case of please answer. Is it mania? Is it schizophrenia? Is it delusional disorder? Or is it a anxiety disorder? Catch point here, first catch point is symptoms for last 20 years. Means symptoms are continuously present for last 20 years. Second thing, lady has had auditory hallucinations. Aliens are talking with her. So first, duration. If we see duration of this illness, it is more than 1 month. Yes, symptoms are present for 20 years. First point. Second, lady is having auditory hallucinations. Auditory hallucinations. Next important symptom, aliens are controlling her with some electromagnetic radiations. So this is what? Delusion of control. Delusion of control. Correct? Next important symptom is patient doesn't goes for her work and become asocial. So these are what? Negative symptoms of schizophrenia. So lady has had negative symptoms as well. So the duration of this illness is more than 1 month, or we can say for 20 years. There is auditory hallucination, there is delusion, and there are negative symptoms. So this is a clear-cut case of schizophrenia. The correct diagnosis of this case is schizophrenia. Okay. So you might think that why not mania, why not delusional disorder? If you remember in our classes, I have clearly told you that in delusional disorder, whenever a patient has had delusional disorder, in such case, there will be only one symptom. Which symptom? Delusion. Only delusion. Nothing else. There will be no negative symptoms. There will be no auditory hallucinations. Patient is able to maintain his social and occupational life in delusional disorder. So in delusional disorder, the only major symptom will be delusion. But here in our case, there are three symptoms: auditory hallucination, delusion of control, and negative symptoms. Correct? So this is not delusional disorder. We ruled out delusional disorder. Next, why not anxiety disorder? Is there is any symptoms of anxiety mentioned in the question? That patient is having tachycardia, breathing difficulty, or fear of impending doom, or patient develop fear of escaping out from some particular condition, or is there is any fear of closed space, or while traveling in train, lift, plane, anything. Nothing is mentioned in this question. Second thing, there is no excessive worry about day-to-day mundane activities of daily life. So none of the anxiety symptoms were there in this question. So this is also not anxiety disorder. Now, why not mania? We already know which are the symptoms of mania: elevated mood, increased energy, over talkativeness, increased spending of money, distractibility, decreased need for sleep, involvement in abnormal activities which has painful consequences later on. So these are various symptoms of mania. None of the symptoms of mania mentioned in this question So in simple words, this is the clear-cut case of schizophrenia. I am hoping that all of you have marked this question correctly. Answer of this question correctly. Okay, let us look at our second question. A psychiatrist is doing mental status examination. We have discussed various parameters, various points about mental status examination in our classes. So a psychiatrist is doing mental status examination of a patient and asked him, means psychiatrist asked from the patient to subtract 7 from 100, means psychiatrist told patient that do 100 minus 7 for 5 times. What does psychiatrist want to assess? So if you see your notes or previous videos, we have discussed in mental status examination. Look, physician does physical examination, and we as a psychiatrist, we do mental status examination, because we are dealing with mental state of the patient. So we do mental status examination, and in mental status examination we ask certain questions from the patient to evaluate, to assess his mental status. So in mental status examination, whenever we want to assess cognition, in cognition we assess two things. One is memory, second is attention and concentration level of the patient. Attention and concentration level of the patient. So we assess memory by two methods. One is digit span forward test, second is digit span backward test. So in digit span forward test, psychiatrist speaks certain digits in front of the patient, and patient has to repeat the digits in same order. Suppose I as a psychiatrist, if I speak or if I say 1, 2, 3, patient has to repeat the digits in same order, 1, 2, 3. Second is digit span backwards. This digit span backward test is specifically used for checking immediate memory. This digit span backward test is used to assess immediate memory. Specifically, this is more, authentic. We do both of these tests, digit span forward as well as backward, but digit span backward test is more specific for checking immediate memory of the patient. So in digit span backwards, if a psychiatrist speaks or say few digits 1, 2, 3, patient has to repeat the same digits in reverse order. Suppose if I speak 1, 2, 3, patient has to say 3, 2, 1. Suppose if I speak 1, 2, 3, patient will speak 3, 2, 1 in reverse order, digit in reverse order. So this is digit span backward, and this is used for assessment of memory. Now, how we assess concentration, attention and concentration level of the patient? For this, either we can say patient to spell the word world in reverse order. Either we can say spell the word world in reverse order, starting from D, D, L, R, O, W. So if patient does so, then his or her attention and concentration is considered all right. Or we can say do 100 minus 7 for 5 times. 100 minus 7 for 5 times, not less than that. Suppose if patient does 100 minus 7 for 2 times, only for 2 times, then we can say that attention of this patient is all right, but concentration is disturbed. But if patient does all 100 minus 7 for 5 times, that means 100 minus 7, 93, 93 minus 7, 86, 86 minus 7, 79, 72, 65. So if patient does this for 5 times, then we can say attention and concentration both intact. So more specifically, concentration of this patient is intact if patient able to do 100 minus 7 100 minus 7 for 5 times. So specifically it points towards concentration level of the patient. So by this method, psychiatrists want to assess what? Level of concentration in the patient. Level of concentration in the patient. Ideal answer would be attention and concentration, but here attention is given in other option and concentration in other option. So by default, if patient does for 5 times, then his or her concentration is considered intact. All right. For assessment of orientation, we simply ask questions that please tell me where are you, what is the time now, which place is this. So we can assess time orientation by asking time, place and person. Time, place and person. So this is not the assessment of orientation. This question is not about the assessment of orientation. It is not about attention. Second, confusion. For assessment of level of confusion, we use what? CAM, confusion assessment method, which we usually do in delirium. In cases of delirium, we use this CAM to assess the level of confusion assessment method. Correct? So this is not for the level of assessment of confusion. So this test 100 minus 7 5 times is used for assessment of the level of concentration in the patient. Hope this is clear. Again, very simple, very extremely simple question. I always, whenever I teach psychiatry, I always focus upon these points, that always remember this question might come in your exam. Okay, so let us see what is the question. Which of the following does not suggest organic cause? Or few students, they were telling that this is something like medical cause. There is some, it is written over there in exam that which of the following does not suggest medical cause of mental illness. So medical cause, it means organic cause. So if you remember, in our classes we have discussed points about organic mental disorders and functional mental disorders. Organic mental disorders are those mental disorders in which there is gross anatomical abnormality present in the brain. Means if you do MRI, CT scan of that patient who is suffering from mental disorder, you will find some pathology in that. There is a grossly visible anatomical deformity pathology in the tissues of the brain, neurons of the brain. So that is organic mental disorder, when symptoms of mental disorder arises because of some abnormality of the brain. That means there is some medical problem. There is some medical problem, definite medical problem in the patient. If we talk about functional mental disorders, you will not find any kind of pathology. If you do CT scan, MRI of the patient who is suffering from mental disorder, you will not find any pathology in their CT or MRI. It means anatomically or medically brain is absolutely normal, but there is a problem in normal functioning. Means the problem is so minor, it is at the level of, synapse. The problem is at the level of synapse. It is very minute. So you cannot appreciate that minute problem, minute abnormality in CT or MRI. But there is a problem, but it cannot be appreciated in CT or MRI. That is functional mental disorder. There is a problem in normal functioning of the brain. So here examiner is asking which does not suggest organic cause of mental illness. So for that you should know about you should know the difference between organic and functional mental disorders. So as I told you, organic mental disorder arise due to disease of the brain. In functional mental disorder, brain is anatomically normal. There is no disease in the brain. Second, onset. Suppose if anyone develops infarct of left parietal cortex, that patient will develop symptoms of paralysis immediately. So onset of organic mental disorder is acute, or even we can say abrupt. Onset of functional mental disorder is gradual or insidious. It takes time. Insidious. Age. We see these type of abnormalities like infarct, hemorrhage, uh, cerebral atrophy. Where? In old age. So organic mental disorders seen in old age. Functional mental disorder is seen in, it is usually commonly seen in young age. It is commonly seen in young age. Consciousness. We usually found this type of patients where a patient who has had infarct, hemorrhage, such kind of things, those patients were admitted in ICU because their consciousness gets impaired. Their consciousness level was impaired, or their consciousness level has been impaired. Here it is preserved. Consciousness is preserved in functional mental disorders. Consciousness is preserved in functional mental disorders. Hallucinations. Hallucinations are mainly visual in organic mental disorder, and it is auditory type. Hallucinations are auditory type in functional mental disorders. It is auditory type in functional mental disorders. Neurological deficit. Neurological deficit is always present in organic mental disorder, but it is absent in functional mental disorders. So, except delirium, dementia, Wernicke-Korsakoff syndrome, rest all other psychiatric disorders are functional mental disorders. Right? So, let us look at the question. Which of the following does not suggest organic cause? Visual hallucinations suggest organic cause of mental illness. Acute onset suggests organic cause of mental illness. Old age suggests organic cause of mental illness. Auditory hallucinations are commonly seen in functional mental disorders. So it does not suggest auditory hallucinations. It does not suggest organic mental disorder. So correct answer is option number D, auditory hallucinations. Auditory hallucinations. Clear? Okay. Next MCQ, again simple, very simple. It is a question of psychopharmacology. A 40-year-old male was taking antidepressant drug for 6 months but has developed sexual dysfunction now. Which drug will be the best alternative for his problem? So when we were discussing about antidepressant drugs, I have told you that most of the antidepressant drugs, especially SSRI, tricyclic antidepressants, SNRI, especially these three groups of antidepressant drugs causes sexual dysfunction. It causes sexual dysfunction. So SSRIs, you already know, SSRIs include what? escitalopram, paroxetine, escitalopram, paroxetine, sertraline, fluoxetine. These are few selective serotonin reuptake inhibitor drugs which produces sexual dysfunction. Tricyclic antidepressant drugs like imipramine, amitriptyline. These are tricyclic antidepressant drugs, again produces sexual dysfunction. SNRI, select sorry serotonergic noradrenaline reuptake inhibitors or serotonin noradrenaline reuptake inhibitor. Venlafaxine, desvenlafaxine, sorry venlafaxine, desvenlafaxine, milnacipran, levomilnacipran. These are serotonin noradrenaline reuptake inhibitor drugs. These three category of drugs produces sexual dysfunction. So which which do not produce a sexual side effects, antidepressant drugs which do not produce sexual dysfunction in the patient, these drugs are: one is bupropion, it is NDRI, noradrenaline dopamine reuptake inhibitor. Second drug is mirtazapine. NASA, the group of mirtazapine is NASA, noradrenergic specific serotonergic antidepressant. So these two drugs do not produce any sexual side effects in the patient. So even if any patient develops sexual side effects with the above mentioned drugs, we can switch them to these two drugs. So here the answer will be what? Bupropion. Because sertraline produces sexual side effect, desvenlafaxine produces sexual side effect, tricyclic antidepressant and even escitalopram produces sexual dysfunction. So we are left with bupropion, which is NDRI, and it does not produce any sexual side effect in the patient. Again, this is a very simple question, very simple question related to lithium. A 27-year-old female taking lithium for her bipolar disorder. Which of the following statement is false about lithium? A lady is taking lithium Examiner is asking which of the following statement is false about lithium. First, let us look at the options. Thiazide diuretics increases lithium toxicity. Yes. If we give any diuretic, especially thiazide, so what happens? Thiazide also comes out in urine from the same path from where lithium is excreted. So thiazide blocks the excretion of lithium. So lithium gets collected in the body and produces lithium toxicity. Apart from thiazide, if you give NSAIDs, it also increases the level of lithium in the body and produces lithium toxicity. If you give ACE inhibitors, lisinopril, captopril, antihypertensive drugs, ACE inhibitors. If you give ACE inhibitor along with the lithium, it also produces lithium toxicity. So these three drugs increases the level of lithium and produces toxicity. So our first option is correct. It is not false. Okay, now let us look at third option. Lithium decreases thyroid levels. Yes. What happens in thyroid gland? Lithium, being a cation, replaces iodide. Lithium replaces iodide in thyroid gland and decreases the production of thyroid hormone. Both are cations. So lithium replaces iodide in thyroid gland and it decreases the synthesis or production of thyroid hormone. So ultimately it decreases the level of thyroid hormone or produces hypothyroidism commonly. So this option is also correct. Lithium is avoided in pregnancy due to its teratogenic side effects. Is it true? Yes, this is also true. Lithium has teratogenic side effects. Lithium produces what? It produces Epstein's anomaly in the heart of the fetus. If lithium is given during pregnancy, it produces Epstein's anomaly in the heart of the fetus. So lithium is always avoided during pregnancy because of its teratogenic side effects. Yes, yes. So we are left with option number B. Let us look at it. Hemodialysis is not useful in lithium toxicity. What is lithium toxicity? When lithium produces toxicity, when the level of lithium goes beyond 1.5 milliequivalent per liter. When the level of lithium goes beyond 1.5 milliequivalent per liter, it produces toxicity. So to control or to treat lithium symptoms, sign and symptoms of lithium toxicity, first thing what we do, we stop lithium. आपको पहले लिथियम बंद करनी पड़ेगी. So we first stop lithium. Second, we can go for hemodialysis. This is the best alternative that we can go for hemodialysis, especially when the level of lithium is more than 4 milli equivalent per liter. So it is best to do hemodialysis to control lithium toxicity or to treat lithium toxicity. Correct? So option number B is definitely true. Sorry, it is false, that hemodialysis is not useful in lithium toxicity. It is useful in lithium toxicity. So this option is false. So our answer of this question is option number B. Do you know which are the side effects of lithium? Side effects of lithium. Side effects of lithium can be remembered with the help of mnemonic lithium. Li. Lithium causes increase in leukocyte count. It causes increase in leukocyte count. T for tremors, which is the most common side effect of lithium. Fine tremors of hands. H for hypothyroidism. H for hypothyroidism. IU means increase urine output. It means lithium produces diabetes insipidus. And it is contraindicated in mothers, those who are pregnant. It is contraindicated in mothers, those who are pregnant, because lithium produces teratogenic side effects in the fetus. So we can remember side effects of lithium with the help of this mnemonic lithium. Correct? Again, this is a very simple question, IQ based question. Even if you don't know about cannabis, overdose, poisoning, anything, you have marked this answer correctly. Which of the following is the most common symptom of cannabis poisoning or overdose? Depression, anxiety, altered level of consciousness with dream-like state, or clear mind. So if you remember, during cannabis intoxication or poisoning, when person consumes large quantity of cannabis, patient develops certain symptoms. Most common physical sign seen after consuming large quantity of cannabis is redness of eyes. Redness of eyes, increased thirst, dry mouth, increased appetite, there is redness of eyes, increased thirst, dryness of mouth, increased appetite. These are the physical signs. Mental sign, there is euphoria, feeling high. There is a development of dream like state. There is a development of dream like state after consuming cannabis. Patient feels euphoric, excessive cheerfulness, high. Wow, what a pleasure. And they go into dream like state. Even the sounds are seen and colors are heard. So they go into a dream like state. They are not in their original self. This is the psychological effects of cannabis intoxication. And ultimately patient becomes confused because they are not in their normal self. They are confused. They are in some other world. They feel that they are in some other world. They are feeling euphoric, cheerful, high. They enjoy listening to music because the sounds are seen and colors are heard. And ultimately they are in a state of confusion, confused level of orientation. They become confused. They are not in their original self. Right? Now, suppose person has consumed a large amount of cannabis, so they develop all these symptoms. Now, when the effect of cannabis goes away, then patient develops withdrawal symptoms. Though cannabis does not produce any specific physical dependence, though it has psychological dependence. Even cannabis is considered as gateway drug. Gateway drug means if somebody consumes cannabis, he will likely to consume other drugs as well, because cannabis opens the gate for consumption of other drugs. So it is considered as a gateway drug. यदि आपने cannabis लिया है तो आप दूसरी और drugs भी try करना चाहेंगे, definitely. इसलिए इसे gateway drug भी कहते हैं. So suppose somebody stops taking cannabis, he may develop mild physical withdrawal symptoms. So because we are living in India and we are consuming Indian cannabis, so withdrawal symptoms are also remembered with the help of this mnemonic Indian cannabis. I for irritability, N for nausea, D for depressed mood, I for insomnia, A for anxiety, C for craving for cannabis, D for decreased weight, A for decreased appetite, so these are few withdrawal symptoms of cannabis: irritability, nausea, depressed mood, decreased weight, insomnia, anxiety, decreased appetite, and craving for cannabis. So these are the few withdrawal symptoms we see in cannabis use disorder. During withdrawal, when somebody stops using cannabis, they may develop these mild withdrawal symptoms. So let us look at the question: which of the following is the most common symptom of cannabis overdose? Depression is seen in cannabis withdrawal, so not in overdose. Anxiety is also seen in cannabis withdrawal. Clear mind is not seen in intoxication, rather confused mind. Patient becomes confused, not clear. Their mind becomes confused. So clear mind is not seen during intoxication. So what we see during intoxication or poisoning: altered level of consciousness with dream-like state. Because patient becomes euphoric, they go in dream-like state, that they are in a uh, they are in a level of they are in a place where they enjoy, they see music and they hear colors. So sounds are seen and colors are heard, so they are in a different state, which is considered as a dream like state, because they are confused. So these are the 6 questions of psychiatry which were asked by the examiner in your exam this January 2023. So hope I have cleared all these questions and their answers, why this answer is of this particular question. And I want to say that all the best, बी पॉजिटिव. आप ऐसा मत सोचिए कि हमारे कुछ क्वेश्चंस, यदि आपके क्वेश्चंस गलत भी हो गए, इफ इवन इफ यू हैव मार्क्ड many questions incorrectly, don't be upset, don't think negative, be positive. बहुत सारे क्वेश्चंस गलत भी हो जाते हैं कई बार एग्जाम में, तब भी एग्जाम क्लियर हो जाता है. और ये इकलौता एग्जाम नहीं है, इसके बाद भी बहुत से एग्जाम होने हैं. हमारा जीवन ही एक एग्जाम है, कदम कदम पे हमें एग्जाम देने पड़ते हैं. तो सिर्फ एफएमजी का जो एग्जाम है वो आपका एग्जाम नहीं है. जीवन में बहुत से एग्जाम्स आते हैं, बहुत से एग्जाम्स चले जाते हैं. सो बी कॉन्फिडेंट, बी पॉजिटिव, and I wish and I hope that all 100% of the students, those who are watching this video, will pass their FMG exam with flying colors. And even if you don't pass this exam, don't worry, you will have another chance in June or July. So ऐसा नहीं है कि मौका चला गया, 6 महीने फिर से है, हम पढ़ेंगे, हम क्लियर कर लेंगे. लेकिन यदि आप पास हो जाते हैं तो बहुत ही अच्छी बात है, इससे अच्छी बात कुछ हो ही नहीं सकती, क्योंकि दिस इज वन ऑफ द बैरियर, unnecessary barrier in your path of success. Because after passing this exam, you have to appear for you have to join your internship. After 1 year or 2 years, you will appear for your PG exam. By that time, there will be much more competition, much more doctors, those who will give PG entrance exam. So competition is definitely increasing day by day, but एंजॉय दिस कंपटीशन, एंजॉय दिस मोमेंट। हर पल को आप एंजॉय करना सीखिए, चाहे वो सक्सेस हो या फेलियर हो। यदि हम सक्सेस होते हैं तब भी हम कुछ सीखते हैं, और जब हम फेल होते हैं तब भी हम कुछ सीखते हैं, जो कि हमारे जीवन में बहुत काम आता है। मैं भी अपने लाइफ में बहुत बार फेल हुआ हूँ, लेकिन मैंने कभी हार नहीं मानी, चलते ही रहा और आपके सामने। सो बी